Thank you very much. Thanks so much to the Maloy family, to Georgetown, to the school, to all of you, and to my friend Tony Fauci for joining me in this. I'm going to share with you a formula, an approach that has already saved millions of lives. It has the potential to save millions more, and it's relevant for personal health as well. The approach is see, believe, create. 3 stages. But let me start a little sooner, a little earlier in my career, in my life. When I was growing up and a teenager wondering, what's the purpose of life? Why am I here? What should I do? I would ask my father, who was a wonderful man, a kind and gentle cardiologist. He was a doctor's doctor who, when any doctor had an illness, that's the person they went to. And Dad would say very simply, you got to help the people. Very straightforward perspective. A few years later, I was wondering what kind of career to go into, and he and I were taking a hike through the Blue Ridge Mountains of Virginia, and he said, you know, you seem to like policy issues and you like scientific issues, and if you put those 2 things together, you get public health. And I'd never heard the term public health before, but that was the beginning of a long hike that I've taken in this field. Fast forward a few more years, I had been New York City Assistant Commissioner of Health. I had gone to India for 5 years to work on tuberculosis control there. I came back, my father was in a nursing home, and he had Parkinson's disease. His health was declining rapidly. And I sat with him and I said, you know, not that I'm competitive or anything. I said, Dad, I want to be the best health commissioner. And he said, and these ended up being the last words he ever spoke to me, how would you know? And it's a great question, right? How do we know if we're helping the people? How do we know if we're saving lives? The first step is see, in the see, believe, create structure. Saving lives is really easy. We just start by seeing things that are invisible. And this is something that was discovered. This is a public health superpower, to see the invisible. And it was discovered more than 350 years ago by a cloth merchant in London named John Graunt. He wrote the first ever epidemiologic analysis in human history. Never before had anyone actually analyzed the rates of disease, the risks of disease, identified emerging infections, found risk factors for death, hypothesized that coal was unhealthy and might increase death rates because it had just begun being burned in large quantities in London, described emerging diseases and the economic impacts of different diseases. But disease trends, important as they are just one aspect of seeing the invisible. It's important to be able to see microbes. Early on in my career, when I was an epidemic intelligence service officer in New York City, an alert clinician called and said, I think we have an increase in multi-drug resistant tuberculosis. And it turned out that she was right. And MDR-TB, as it's called, was spreading widely through the city, but we could only know that because we could do the surveillance. We could only know that because we could mandate laboratories to send samples to a standard laboratory to be tested. And we still didn't know where it was spreading in New York City. Was it homeless shelters? Was it on the subway, which is what the tabloids were saying? And we were able to do probably the first community-wide genomic epidemiologic study. And we found that, in fact, it was spreading in hospitals. Hospitals were the Broad Street pump of multi-drug resistant tuberculosis in New York City in the 1980s and early 90s. So we could see the invisible trends and therefore stop them. Dr. Fauci and I worked together during the Ebola epidemic of 2014 to 2016. And for many months, we couldn't convince people to act. We couldn't explain how urgent the situation was. And then a disease model the CDC, done by Martin Meltzer, showed that unless urgent action was taken, there would be 1 million cases of Ebola within another 7 months. And that hockey stick graph galvanized action in the US and globally. Interestingly, that model also predicted that if we got to at least 70% safe care and 70% safe and dignified burial, cases would fall just as rapidly as they had increased. Something that I would never have predicted, but that this disease model did predict. That model led to a dramatic response. It led to, in fact, meeting those 70-70 targets, and the disease came down just exactly in the pattern that had been predicted by the model. So seeing isn't just about seeing risks. It's also about seeing the path to progress. And it's also about seeing why we don't take that path so very often. Why, even though it's clear that if we continue on this path, something bad is going to happen, we continue anyway. This is something that's been referred to as the Cassandra curse. Cassandra was a priestess in Greek mythology. She was blessed with foresight. She could see the future. She knew what was going to happen, but she was cursed. Nobody would believe her, and so they wouldn't take the actions that would prevent the tragedies that she could foresee. And in this book, I gave a lot of thought, did a lot of research about why does the Cassandra curse exist? Right? It doesn't make sense. If we know something bad's going to happen, why don't we avoid it? And it comes down fundamentally to inaccurate perceptions of reality. And by having better perceptions of reality, by seeing more accurately, we can avoid that. So that's the easy part, seeing the invisible. Then it comes to believing the impossible. All too often, we think that the present patterns are inevitable. There is this illusion of inexorability, that things are the way they are, they'll stay this way forever, and we need to break that illusion. We need to shatter that illusion, because only if we think we can make a difference will we make a difference. Tony and others created PEPFAR under President George W. Bush. This was a world-changing program. He probably doesn't remember this, but I first met Tony when I was a medical resident in New York City. And I had a patient who I still remember very vividly, who was dying of AIDS. And he had a terrible neuropathy. And AZT had just come out. And I called to try to get AZT for him. And he didn't meet criteria. It wouldn't have helped him much for long. But PEPFAR changed the world. So believing is very important. There's a tendency of public health people to not emphasize past progress, because we think that that may lead us to say, mission accomplished, we've done enough, don't need to do anything more. But things can be bad, but better. Better, but still bad. And showing that there's been a lot of progress doesn't have to mean, hey, you can take your foot off the accelerator and relax. It can mean, hey, we've made a lot of progress, so we can make a lot more. And that's one aspect of strengthening belief in the possibility of change. Another is to implement phased programs. And I learned this from a really remarkable scientist named Carol Stieblo. And again, in doing the research for this book, although I'd met and worked with Stieblo, I really didn't understand just how deep and brilliant his knowledge was of public health, of epidemiologic trends, of how to implement programs, of what works in public health. And what Stieblo explained is when you're going to expand a program, choose a couple of areas, choose really good leaders, make sure you can get there often, and then have a phased expanse. All too often in health programs, we are beset by a disease. The disease is called pilotitis. There are pilots that never scale. So you have to strengthen the belief in the possibility of progress by making progress in a systematic, phased way. And finally, you have to cultivate optimism. Now, optimism may seem delusional given some of the challenges that we have today, whether it's in our climate or our political climate or the developments in various parts of the world. But actually, there really are rational grounds for optimism. Dr. Bill Foege, who led the global eradication of smallpox, was working in India, and he was doing all sorts of things in that job posted to India, hiring and supervising and procuring and running meetings and dealing with politicians. And someone came to check on him and said, "What is your job description?" And he said, "Resident con man. My job is to keep people believing we can do this." But it wasn't a con. It was rallying the troops. And with that rallying, 200,000 healthcare workers in more than 70 countries found more than 10 million contacts of patients with smallpox, vaccinated them, quarantined them, and eradicated smallpox from the world forever. After the eradication of smallpox, Foege was asked, "What next?" And he said, "The eradication of bad management." Because even if you see the invisible and believe the impossible, you then have to do what really is hard, which is to create a healthier future. And that means organizing well. It also means achieving simplicity, which, as Leonardo da Vinci wrote, is the ultimate sophistication. When I was working in New York City, my first big job running the tuberculosis control program, I was working around the clock, but I wasn't making much progress. And Dr. Carol Stiebler came to New York City. He analyzed our data, showed me things that I had missed, and then he asked me a question that changed my life. He said, "Dr. Frieden, this booklet you showed me says that last year you diagnosed 3,811 patients with tuberculosis in New York City, but it doesn't tell me the most important thing." I said, "What's that?" "How many of them did your team cure?" And I didn't know. And I was really ashamed because it was an obvious question. But that kind of simplicity is lacking from our healthcare system. How many patients whose cancer should have been caught early had their cancer caught early? How many patients who have high blood pressure have it adequately treated? How many patients who should be on a statin are on a statin? These are basic questions, and we can't answer them accurately because we don't have that simplicity. But even if you organize and simplify, you have to communicate well, listen well, with the right messengers, the right messages, the right timing, and adapting, explaining that the world changes. People would like to say, "Oh, just tell me the truth and we'll stick with that." But that's not how science works. Science doesn't give you certainty, it gives you humility. Microbes change, our immunity changes, vaccines and treatments change, the environment changes, and with all of those things, our ability to understand the world and improve it increases. Simplify, communicate, organize, and overcome barriers, because there will always be substantial barriers to effective public health action. There will always be powerful forces, whether they're companies like the tobacco company or internal forces like our perceptions that make it difficult to make progress. But there has been enormous progress in public health. And despite the challenges, despite the fact that we are in difficult times, we can make more progress still. When I was New York City tuberculosis control officer, we had advocated for years to get resources to renovate the tuberculosis clinics. Not a popular cause. The clinics were in horrible shape. They were filthy. They were unsafe. They were unpleasant. But we, with a lot of advocacy, we got a multi-million-dollar, multi-year commitment to renovate the clinics. And then mayoral elections happened, and one mayor went out and one mayor came in. And the new mayor was Rudy Giuliani. And we were really afraid that we would lose our funding for renovating the clinics and not be able to take care of TB patients well. There was a letter written from the New York Coalition to Eliminate Tuberculosis to the mayor saying, we demand that you continue those renovations. That letter sifted down to me to draft a reply. I had no idea what to say. It was the first week of the new administration. I wrote a mealy-mouthed reply that said, we'll do the best we can, went back up the chain, all the way to the deputy mayor, and came back with a handwritten note. No, tell them we're going to renovate those clinics. And we did. The New York Coalition to Eliminate Tuberculosis, that letter was written on a manual typewriter by a man named Charles Ehlers, who was a cured tuberculosis patient, and he was actually the New York Coalition to Eliminate Tuberculosis. There was no organization, there were no other individuals, but that letter saved the clinics that have treated thousands of patients in the following years. So despite the substantial barriers that we face, it's possible to make real progress. We need to strengthen the bonds of trust in society. We need to be clear about the facts. We need to get back to a world where we can say you are entitled to your own opinion, but not to your own facts. Facts are stubborn things, and even if they're ignored, suppressed, twisted, abused, they're still facts. People want a long and healthy life. The motivations of the Make America Healthy movement are really important. People don't trust our healthcare system. People don't trust our public health system. Many people. People are worried about what's in our water, what's in our food, what's in our air, who's making decisions that affect our lives and our children's lives, and on what basis. Those are totally valid concerns and questions, and we need to address them. We need to not build back, but build forward. A health and public health system that's faster, that's more connected, that has better alliances, that is better at communicating, that delivers tangible progress for people. And by seeing the invisible, believing we can really make more progress, and systematically creating a healthier future, I'm confident that we will do that. Thanks very much.
Okay, so now let's talk a little bit about your book, which okay? The Formula for Better Health, and the title is something that struck me before I read it, but upon reading the book, I pointed this out to Tom a little bit ago. How to Save Millions of Lives, Including Your Own. And Tom, let's just have the audience maybe appreciate the conversation we had. That on reading this book, I was struck by the fact that it's actually two books that are very nicely synergized together about how you can make the world healthy again and how you can make yourself healthy or prevent yourself from being unhealthy. And you do it in such a masterful way where what you talk about personal health is very distinctly related to scientific evidence and data. And the reason I say that, guess what, is that a lot what we're hearing right now about health is not based on any data at all. In fact, it's based on perhaps misinformation and disinformation. So could you tell us a little bit about what got you to sort of synergize those two things? Because if you look at making the world a better place, you could do that by itself in isolation. And what you said about the things, which I'm actually practicing them right now. How did you do that? And what were your thoughts when you put it together?
Well, I began writing this book a decade ago when we were working together on Ebola, because it suddenly became really clear to me that a lot of people don't know what public health is, don't know why they should support it, and frankly, a lot of people doing it aren't doing it as well as they might to succeed more reliably. So I began at that point. It's been a 10-year process, and it was really over time that I was able to put together this concept of the formula. 8 years ago, I founded, and I still lead the organization Resolve to Save Lives. And by the way, all of the proceeds from the book will go to organizations and projects that Resolve supports around the world. And it was clear to me that there are important lessons, there are important ways to think about health that are kind of the way an epidemiologist thinks. And they're different from how a basic scientist thinks, and they're different from how a clinician thinks. And they're not better, but it's a different perspective. And different perspectives have different values. And one of the things that the epidemiologic perspective has is the ability to see the path to progress. And that path is relevant, and that methodology of seeing that path is relevant for community health, and it's also relevant for individual health. And toward the end of the writing process, it began to get clear to me that, oh, this isn't just about what works in public health. It's also about what works in personal health, because so much of what we read, not just in social media that may not be well curated, but even in leading publications, leading newspapers, is the reflection of sometimes it's just grifting and selling stuff. Sometimes it's just hype and trying to make a headline or clickbait. And sometimes it's sloppy thinking, where two risks seem similar, and actually one is very, very small compared to another. Or two perspectives seem like, oh, there's two valid views, and one is a cherry-picked flaw, and the other is overwhelming evidence. So I found that this idea of identifying the technically rigorous route to progress is relevant not just for how we run public health programs, but also for how we make decisions about our own lives.
Right. So, Tom, one of the things, that there are so many aspects of the book that I really, really like. That's why I really recommend, if you have interest in this, that you read this. This is really a terrific book. You described briefly in your opening remarks the see, believe, create. Under C, you emphasize something that I think is very much underemphasized, is the whole concept of surveillance. And you used the issue with hypertension as your primary example of that, together with TB. But I was struck by the issue of hypertensive. You want to tell the audience a little bit about our underestimation of hypertension and how surveillance has now brought that to the fore?
It's really interesting. I'll tell you a story. When I was health commissioner of New York City, we decided that we would have a big project to put electronic health records into the South Bronx, Central Brooklyn, and Harlem, the three sickest, poorest neighborhoods in the city. And we got Mayor Bloomberg to make a commitment when he was running for re-election to put in these health records. We got $27 million. We put in the health records, and as they were going in, I met with Dr. Farzad Mostashari, brilliant, brilliant physician who became the head of National Health IT for the United States. And we said, okay, we're going to have all these health records in. How are we going to save the most lives? A very straightforward question. How can you save the most lives with health care? And we looked at each other and we said, we don't know. So we did a Medline search, 10 million articles, not one article on that simple question. Remember the Stiblo simplicity. How can you save the most lives in healthcare? So we had to do the analysis, and it's been replicated since, and it hands down it's hypertension control. Not even close. The next highest thing is probably statins, maybe half as many lives saved as hypertension control or thereabouts. So hypertension is the silent killer. For many people, maybe even most, the first symptom you'll ever have is a heart attack or stroke. It kills about 11 million people around the world. That's 1 out of every 5 deaths. It kills more people than all infectious diseases combined. And yet, it's preventable and treatable. And our group, Resolve to Save Lives, has worked with 40 countries to support these countries, which have now put more than 40 million patients on treatment in primary care to treat hypertension. But it is the quintessential invisible killer.
It is called, the invisible killer. Right. And in order to really make progress, you have to see what is not immediately apparent. And we learn more all the time about the harms of hypertension. A recent study showed that if you control hypertension to 130 rather than 140, you reduce the risk of dementia substantially. So I think this is an example of seeing things. And another aspect of surveillance, which you raised, is the importance of rigorous studies. If you check your clinical indicators, it may look like, if you're seeing from healthcare systems, oh, you got 70, 80% of people controlled. But if you do a community-wide survey, it may be only 30 or 40%. So it's seeing what's reality.
Yeah, the number that you put into the chapter is very interesting for the audience to hear. If you start off at a blood pressure of 115/75, every 25-point increase above that increases your chance of stroke or heart disease. Why don't you tell them about that? That's amazing.
These were brilliant studies done in multiple countries by a group in Oxford, prospective cohort studies with millions of patients. And they showed that there's a linear relationship. Starting at 115/75, every 20-point increase doubles your risk of having a heart attack, stroke, or death before age 70. So if you go to the doctor and they say, oh, your blood pressure is fine, it's 135 over 88, like, no, it's not fine. It's twice what a healthy rate will be. And what's more, really interesting studies done in the 80s showed that there's a correlation between how much sodium we consume and how high our blood pressure is. And they identified 4 communities, they were generally pre-industrial communities, which consumed really minuscule amounts of sodium, like a 10th what we consume or a 7th what we consume, and there was no hypertension in these communities, none. Their blood pressure was 90/60 at age 16 and 90/60 at age 60.
I only wish.
Right, 90% of Americans over the age of 65 have hypertension.
Yeah, but the other thing that, on reading that chapter, that struck me, and we're both physicians, as physicians, is one of the most tragic things about these silent killers. It's a reflection of some of the devastating consequences of the lack of easy accessibility to health care. So one of the most tragic things that we face a lot of tragic things when you're practicing medicine, but one of them is to get a young individual, relatively young, 35, 40 years old, who comes in and you do a blood pressure on them and they're 195/110, and then you do a creatinine or a BUN and you find out they're already in hypertensive renal failure, which is completely avoidable if you have the opportunity to get that person examined early enough to interfere with. But it just is such a tragic example of the silent nature of hypertension.
It's also a reflection of how much more progress we need to make on health care in this country.
That's the point.
100 million Americans don't have a primary care doctor or clinician. 100 million, that's basically 1 out of 3 people. And we spend $4.5 trillion on health care. And if you look at hypertension control, the single most important thing to do in health care, we don't get it right even half the time.
Yeah. Very true. I lived through this with Tom when he was the Commissioner of Health of New York City. So explain to the audience what it feels like when you're trying to get people to not smoke in bars who want to smoke in bars. I mean, I get death threats for other reasons. You would get death threats for people who wanted to smoke. So why don't you tell them because what you did in New York City with Mayor Bloomberg was just spectacular, and I think the audience needs to hear about this.
Thank you. Well, I was working in India, working on tuberculosis. It was wonderful, very hard, but very rewarding work with the government of India, states of India, the World Health Organization, the World Bank, and the government had been able to scale up effective tuberculosis control services using a WHO technical package, and they were saving millions of lives. But the program was kind of going well. And if you ever work in other countries, what I found in India was my effectiveness was inversely proportional to my visibility. So the more invisible I was, the more I could get done. The more people noticed that I was there, the less effective I was. And after 5 years, it was hard to hide. So I was finding myself being less effective there, and then 9/11 happened. I was born in New York City. I did my residency, my medical school residency, public health school, all there. I had done my epidemic intelligence service training there and been the head of TB there. It was my home. And I felt like, you know, if there's something I can do to support New York City, I will. Mike Bloomberg got elected, asked me to become health commissioner. I'm an epidemiologist, so what did I do? I downloaded the statistical analysis of deaths in New York City. And I say, well, what are people dying from? I've been totally immersed in tuberculosis for more than a decade. And it's like, wow, they haven't stopped smoking there yet. Smoking, hands down, is the #1 preventable cause of death in the US and globally. And so I basically said, you know, I didn't know Bloomberg at all. I said, you know, I'll only come back if you're willing to take on the tobacco companies. And he said, no problem. And early on, he raised the tobacco tax. State had to do it, but he forced the state to do it by $1.42 per pack. A pack of tobacco now costs something like $11, $12 in New York City. And then the next thing to do was to go smoke-free, because that would have the biggest impact. And there's no reason that someone serving food in a restaurant or drinks in a bar should get cancer because someone's smoking at their workplace. But it was a massive fight. And for me, it was more an advocacy issue. We in the formula, Chapter 8 is about how you overcome barriers by looking at winners and losers, advocates and champions and partnerships, deciders and influencers, pragmatism and timing, and getting the Smoke-Free Air Act through the New York City Council was an all-out struggle. And it required Bloomberg going to the mat, it required courageous city council members, it required overcoming the objections of the city council chief, who was not very in favor of it. It was really hard. But politically, it was even harder. Mike Bloomberg likes to say, if you ever want a character-building experience, ban smoking in bars, then go on a parade in Staten Island, where there's a very high smoking rate, where you get a lot of one-finger waves that say, and signs that say, I smoke and I vote. But by a year after the time when the Smoke-Free Air Act went into effect, people loved it. Even smokers loved it. Smokers don't like eating in a place that smells like an ashtray. So what's interesting, the mayor had a chief of staff, Peter Madonia, who's very strategic. And he told me something early on about timing. He said, do the hard stuff first. Because, you know, a new administration has a lot of political capital. And that, like a new car that you drive off the lot, the minute you drive it off, it starts going down fast. So Bloomberg knew he had only a limited period of time to get stuff done. By the time re-election came around, it was a success story. People liked it.
So, but, you know, it was bad enough you took the cigarettes away, but then you try to take the Coca-Cola and the Pepsi-Cola away. What happened there? The next thing you want to take their guns away, Tom. I mean, really.
So what I tried to do about soda was to tax it.
Yeah.
What's interesting, if you look at the data for the US, our physical activity hasn't gone down a lot in the time that obesity has skyrocketed. Our calorie consumption has gone up by about 300 calories per person per day, half of that through soda.
Really?
If you look at the amount of soda being consumed in the US, the average American consumed as a treat 1 glass of soda every 2 or 3 days. Now, the average American consumes 2 glasses of soda every day.
Really? Really? Wow.
So we could predict that taxation would be the most effective way to reduce soda, and that was the single most effective way to address obesity, but we couldn't get it through. Because Coke and Pepsi, though they hate each other, market against each other, they got together to kill that tax. And I think we can learn from that. When we're trying to advocate for health issues, there may be people we don't agree with entirely, but we can make common cause on something like safe streets to walk on, or a healthy environment, or safe water. I was not behind the big gulp, the effort to limit the size of things. I actually vetoed that. When it came to me, I didn't think you could win the kind of court of public opinion on that. But I do think taxing soda and not allowing it to be served in schools or on public property is the way to go.
Right. You know, you've mentioned Mayor Bloomberg, who you successfully worked with for so many years, but I was struck again by just reading some of the statements that were made in the book, and I want to just mention one of them that I want you to maybe amplify a bit with the audience. When you were talking about prevention, you make the point that one life saved by a heroic and well-publicized intervention is a recognized miracle, where millions saved by public health is invisible. And that is really, really true, because if something doesn't happen, if you didn't even know it was going to happen, then you don't recognize that it didn't happen. Whereas when you have someone that you're going to do this very expensive, multi-million-dollar procedure on it to save a single life, you're right, it becomes front page news and not the millions. So you want to talk about that a little? I really like that part of the book.
I've gotten to know, well, Edward Tufte, who wrote the visual presentation of quantitative data, the kind of data visualization guru of all gurus, has written about the value of a statistical life. That we may not be able to say which life we saved, but we can save many more for much less money than those dramatic cures. But CEA Winslow was one of the founders of public health in the United States, and he has a beautiful quotation on this. He says, "If we had but the gift of second sight to transmute abstract figures into flesh and blood, so that as we walk along the street, we would say, that man would be dead of typhoid fever. That woman would have succumbed to tuberculosis. That rosy infant would be in its coffin. Then only should we begin to have a faint conception of the silent victories of public health."
Right.
At Resolve to Save Lives, we publish something periodically called Epidemics That Didn't Happen. We identify a team somewhere in the world that did a great thing that stopped an epidemic. And emphasizing that isn't so easy, but just think about the progress that there's been. When I was beginning my public health career, the rate of teen smoking in the US was 36%. Last year it was 4%. And most adults who smoke, 80%, started smoking as teens. So these are enormous changes. The fact that we don't have to boil our water usually, or that we don't have to worry about the kind of pollution in our water, our food, our environment, our air, that will kill us young or increase our risk of dementia or other problems, is a reflection of those silent victories of public health.
Yeah, yeah. You know, the other thing, I wanted to bring it up before, but I'll bring it up again, when you were talking about Cassandra's curse, which, as you very accurately explained, is this Greek mythological figure would be very accurately predicting the future, but nobody ever listened to her. So it was her curse. When I think about that, if we just fast forward to the current day, we might be living through a Cassandra's curse now about measles. Because if, in fact, you do not or under-vaccinate the population, you will get a measles outbreak. So when you were talking about Cassandra's curse, I mean, I say it all the time. When you were in a position as the director of CDC, you were very articulate about the importance of vaccinations. Could you tell the audience a little bit about what's going on in the United States today with our 1,600 cases and what that might mean if we, just the mathematical modeling of it, what it means if we go down? Because I really think they need to hear that from somebody who is in a position as the director of CDC to really have to deal with something like that. So would you do that, please, Tom?
I started as an epidemic intelligence service officer in 1990, disease detective, and I started, and soon after, there was a large outbreak of measles in New York City. We had thousands of cases, hundreds of kids hospitalized, dozens of kids who died from it. And this was the tail end of the measles outbreaks in New York City, and globally, and in the US. In the US, first off, I try to be, as you do, rigorous about what I say. You can't say measles every year killed this many people, because measles tended to come in waves when enough susceptibles were built up. So it tended to come roughly every 3 years. And there were cases every year, but the big outbreaks were every 2 or 3 years. In those big outbreak years, there would be millions of cases, thousands of American kids who would be hospitalized, many of them with meningitis, blindness, deafness, permanent neurological disability, and hundreds of kids would die from measles. Globally, measles remains a leading cause of death. It kills an estimated 100,000 people a year around the world. And measles doesn't just kill by measles. It sets kids back on their growth curve. It undermines their immunity. And in many ways, vaccines are a victim of their own success. People don't see measles. People don't see polio. People don't see meningitis. When I was at CDC, we evaluated rigorously a meningitis vaccination program in Africa, a fantastic vaccine, Menafrivac, that really has ended what used to be called the meningitis belt of meningitis in Africa. And we found 0 to 29-year-olds, more than a 90% uptake in vaccines. They didn't really need to be convinced. They saw people dying from measles and meningitis. So when you don't see that, you need something to keep that up. And what we've seen with the Advisory Committee on Immunization Practices is really horrific. This was a very rigorous entity that very strictly avoided conflict of interest. Everything was transparent on the website. All of the decisions, the reasons for them were clear. I think it could have done a better job communicating those, why it made what decisions, but it was really a best practice. In fact, people came from Korea and all over Latin America to watch it, to replicate that process. And it's been completely dismantled, replaced by individuals who have no experience in vaccine science, and in fact, hold very unscientific beliefs. Decisions made in a chaotic fashion. And for the first time ever, you have the American Societies of Obstetrics, Gynecology, Family Practice, Pediatrics saying, and the insurers saying, we're not going to do what the CDC is recommending because it doesn't make sense. So I think we're seeing really the undermining of the foundations of the public health systems that keep us all safe and healthy. And that's dangerous.
Yeah. So we have 5? Okay, then you want us to stop right now and open it up? Let's do it. I have a lot of questions, but I want to hear from what the audience has too.
So we are going to have students line up at these microphones. I think you'll find that our students at Georgetown are just as tough as Dr. Fauci over here. So we'd like to welcome students and faculty and staff to join us and visitors to come down here. If people don't start lining up, Dr. Fauci has a number of questions to continue asking, but please join us. Why don't you start with one and we'll see who trickles down.
Yeah, well, just what is happening now, as we know, in the arena of public health, is that there is talk and the danger of pulling back on mandates for vaccination of children to get into school. So could you kind of maybe briefly tell me the level of your anxiety about that, Tom, so I can maybe have some commiseration with you?
Well, on a positive note, more than 90% of parents get their kids fully vaccinated.
Yes.
So still, there is overwhelming support and understanding that vaccines save lives. I also think, see the invisible, see, believe, create. See, one of the things we have to see is what's driving a lot of the misinformation. And what's driving it is the profit motive. Right. And they're very upfront about this.
Right.
They want to say that vaccines cause autism, so every kid with autism should be able to get a lawyer who gets rich,
right,
suing the government and getting money from the Vaccine Compensation Fund, even though there's no correlation between vaccines and autism. So I think to the extent maybe that we make the invisible visible, we take some of the wind out of the sails of the misinformation.
Right.
Well, it looks like it didn't take long for them to
That's
line
right,
up.
you got it.
So why don't we start with the longest queue? And if you want to go quicker, you might want to scoot over the other side. Just saying. Why don't you go ahead? Okay. Why don't you announce who you are and what school what you're studying and your question?
Okay. Hi, thank you both for being here. My name is Monse. I'm in the MSFS program studying foreign service. And my question for both of you, as you mentioned, we're living pretty crisis mode right now in the area of public health. We have the Secretary of Health and Human Services telling people not to take Tylenol, saying, all these false claims about autism. We have Florida now not requiring students to get vaccinated in school anymore. So my question for you is, what advice do you have for, the average student, the average American, the average international student here, who don't really know what to trust and what to believe, the people that are supposed to be telling us these things, having really conflicting ideas? How do we move forward? Where do we go from here?
I'm going to ask one person from each side to ask questions so you can address them at the same time because we have so many curious, brilliant students here. Why don't you come forward as well?
Hello? Okay. Hi, Dr. Frieden. Hi, Dr. Fauci. It's an honor to see you all today. So I'm Chakrapani Godlavleti. I'm an undergrad sophomore at School of Foreign Service, studying STIA, concentrating on global public health. So I'm very excited to be here. So over the summer, I did an internship at my city's public health department. I'm from Lexington, Kentucky, and we did have a case of measles outbreak in the central Kentucky region in my city. And the problem was a lot of people, unfortunately, in Kentucky do not trust our medical care system. And oftentimes, especially people in rural areas who tend to have already low health outcomes. So what does public health agencies have to do to first deliver tangible measures to states like Kentucky, and how do we garner that trust to ensure they take the measles vaccines and other preventative measures that are necessary?
Yeah. Go ahead.
There's so many questions. I'm going to be really quick in my response so we can try to get through a lot of them. In terms of where to get advice, who to turn to, I would say it's really important to look at places like the Mayo Clinic that have rigorous advice, to look at the medical societies, especially the general ones, the family practitioners, the obstetricians, the pediatricians, which are not conflicted and are focused on clear outcomes. And increasingly, artificial intelligence is going to be a really important source of information. There are some medical AIs that are, to me, they are mind-blowing. It's like having the best senior resident or chief resident at your fingertips all the time, able to give you an immediate answer. So I think those are important. Yeah. In terms of rebuilding trust, I think it starts with listening to people, communicating better, addressing things that matter to them with tangible wins, and it has to include improving primary health care and access to primary health care, because there's no one better to talk to a reluctant person than their own doctor.
Right. Right. Yeah, just to amplify a little bit what Tom said, I think to both of your questions, is that when you are in a situation where you want to rebuild trust and people seem to be take an anti-vax person or a profoundly hesitant vaccination person, don't put them all into one bucket. because a lot of times people who are hesitant are not really anti-vax. They need more information, and you would be surprised that if you approach them not in a confrontative way, like you don't know what you're talking about, you want to ask them, as Tom was saying, ask them about why they feel a certain way, and then deal with them in a back and forth way about how they can maybe change their mind. Because if you take everybody in the same bucket, as it were, you're going to be being a disservice to the people who are right on that borderline, who do have trust, but they're a little bit squeamy about it because they've heard a lot of things that were probably disinformation. And what they need is some clear-cut, articulated information from you. That would be another way to do it, in addition to what Tom said.
I'll just say that at the height of the COVID pandemic, I did a Zoom focus group with vaccine-hesitant individuals, Trump voters specifically, that Frank Luntz coordinated, and it was the most interesting thing I did during the pandemic. The conversation lasted almost 3 hours, and what was really clear to me was these folks had totally legitimate questions, totally legitimate, and they felt their questions hadn't been answered, they hadn't even been addressed, and they felt they had been vilified for asking those questions. And, took a few hours, but after listening and understanding and talking, most were saying they were willing to get vaccinated.
Yeah.
Excellent. We're going to take actually 3 questions this time. So let's start here, and then here, and then here.
Hi, my name is Maria. I'm also an MSFS student studying foreign service. I kind of had a similar question about reestablishing credibility, so I'm going to pivot a bit and ask, you guys gave some examples on how you would reestablish that trust. I was wondering if you could give us some specific policy approaches that you might think could be effective.
Hi, my name is Karina. I'm an undergraduate in the SFS. I'm studying international political economy and then a minor in health. I was wondering, you mentioned that you worked on the 2014 Ebola outbreak, and when it comes to pandemic outbreak response, how do you cultivate that hope and optimism that you mentioned, and what steps would you recommend for those interested in the field?
Hi, my name is Upasia Swarna. I'm a freshman in the School of Health studying healthcare management and policy. And I know you have some experience working with tuberculosis, so I wanted to ask you about your thoughts on gain-of-function research and what's been going on with that. Some people some scientists do say that it is important, but with, the current halts on a lot of the projects which were centered around tuberculosis, what do you think about the risks versus benefits of that kind of research? And then also, how can you improve transparency and accountability for transnational research, gain-of-function research?
Yeah, let me just, some overlap here, but the idea about trust, one of the things that we have learned, sometimes painfully, is that when you're dealing with a health issue that's evolving, it's fundamentally a moving target. And you've got to treat it as a moving target in the sense of gathering information that is available to you at a given time and letting people know who are the ones you want to trust you that this is information that could change over a period of time. And if you stick to scientific principles, you gather information and you utilize the self-correcting nature of science. And don't ever be afraid to say, I don't know the answer to this, but as we get information, I'll give you information. What many people get put aback by is sometimes scientists either, inadvertently, usually not deliberately, make it seem that this is the answer and that's the answer. And then when things change, they say, well, wait a minute, you told me this 3 weeks ago, and now all of a sudden you're telling me something different. When you're dealing with a moving target, and Ebola was a classic example of a moving target, you've got to be very humble in letting the public know that a lot of it you don't know, but we're just going to tell you what we know.
So there was a lot in those questions. I'd maybe start with the last one about gain of function. I think it's important to think of gain of function not as an on-off switch. There's a range of research, from research that's probably not going to be dangerous, to research that's really dangerous. I oversaw the BSL-4 lab at CDC, where people go in spacesuits and they work with smallpox and Ebola and other things. My belief is that we're doing too much risky research in too many labs with too many staff with not enough safeguards. Now, I don't think we can get to a zero-risk situation, but we can drive down some of those risks by continuously improving safety protocols, by looking at near misses, by improving not just US but global registration of the materials that are used. On optimism, I think it really can seem delusional to say, oh, be optimistic, but it's not about whistling in the dark, right? We have better tools than we've ever had in human history. We have better diagnostics, better treatments, better vaccines. Part of the whiplash over vaccines is because we have so many new vaccines, great vaccines that are more specific, they're more effective, and they use a range of new technologies. Conjugation, which allowed us to end Haemophilus and drive down pneumonia, new subunit vaccines, better adjuvants that are more specific. So there's progress. There's always going to be struggle, but there's more potential for progress than we've ever had in human history.
Yeah, one additional thing about gain of function that's important, you have a lot of misperceptions about gain of function. There's gain of function, which is a broad category, and then there's gain of function of concern that could be possibly dangerous. When you hear people who want to eliminate all gain of function research, and the scientific community gets a severe anxiety reaction, because let me give you an example of gain of function. The influenza vaccine that you hopefully got last year or this year was by making a influenza much more easy to grow in an egg. You're giving it a gain of function. You're modifying its genes so that it easily grows in eggs, because that's how you make an influenza vaccine. You grow it up in eggs and you either inactivate it or you attenuate it and you have it. Another gain of function is you take an E. coli and you stick in the gene for insulin in there, and the E. coli starts spitting out insulin. That's all gain of function. That's something you don't worry about. So when people say gain of function, tell them, what do you mean by gain of function? Do you mean gain of function of concern, the way Tom was talking about, or you're talking about the broad generic term gain of function? Very important.
Excellent, thank you. Let's start on this side, and then we'll do three again.
Good afternoon. It's such an honor to hear you both speak. My name is Martha, and I'm a PhD student in global infectious disease. And so I have two quick questions. One is, everybody's concerned about the vaccine mandates and what's going on with that domestically. With your global experience, I'd really like to know how long before this gets to the rest of the world, both in terms of just vaccine hesitancy, as well as if some of what is happening in the US is actually going to filter to policy and recommendations globally. And then second has to do with TB. You spoke about your experience with TB. I'm originally from Zambia. I have my BCG vaccine. But I'm concerned, you talked about new tools. We haven't had any new medication for TB for 40 years. And they say that our vaccine is about, the BCG vaccine is about 30%, I think, if I'm not correct, efficacious. And so there's multi-drug resistance TB, like how you're optimistic, but I'm just wondering how that plays into how we will control multi-drug resistant TB.
Hi, my name is Abigail Koshi. I'm a freshman in the SFS, and I'm planning on studying culture and politics. Dr. Frieden, you mentioned earlier that science doesn't give certainty. I was wondering, how do you balance the juxtaposition between establishing facts of science to the public of the United States or globally, and the inevitable fact that science is always changing and the facts are always changing? Thank you.
Hi, I'm Sylvie Bissell. I'm a senior in the School of Health studying global health, and I just started my accelerated Master's of Science in Global Health at Georgetown. I'm also a STIA minor. And I really appreciated what you said about learning from our opposition, so to speak, in terms of like big pharma and fast food chains and finding common causes for action. And I'm curious what you think those common causes are currently that have the power to mobilize different groups with very drastically different values and interests toward common public health goals.
Let me ask actually one more, just since we have such.
Hi, my name is Caitlin Randolph. I'm a freshman in the SFS studying international politics. And Dr. Frieden, you mentioned talking about, or you were talking about the idea of progress and making sure that we are always progressing. And in today's political landscape in America, with the dismantling of the CDC and the decline of U.S. healthcare policies, I was wondering how you envision that progress is going to be rebuilt moving forward after, obviously, what has been happening with healthcare in America, and then through which avenues you think that those improvements are going to be made between, whether it's through states or rebuilding the federal systems. Thank you.
All really great questions.
Yeah, so just the question about the changing science, I think is really important, and it had to do with what I said a little bit ago, that when you're dealing, particularly in the health arena, you have to have a degree of humility that the very fact of what, it would be wonderful if there was more science literacy in the country, and I don't mean that everybody needs to be a scientist. I mean, people understand the fundamental concept that science is self-correcting. And if you do it right, something that you observe now, which is a real fact, that might actually change. COVID was such a great example. We thought it was inefficiently transmitted at first, the way the original SARS was. And then we found out, no, it wasn't. It was quite efficiently transmitted. We didn't realize that it was transmitted predominantly by aerosol as opposed by droplets. And then we found out it was. And then we didn't realize that most of the transmissions were from people who were without symptoms. That was a big change from January to April. And the only way we can essentially get people to trust what we say is to explain to them that if you're true to the science, you will be able to change recommendation guideline depending on the latest data.
So there was a question about the global implications of what's happening in the US. I think, unfortunately, or fortunately, vaccine hesitancy will be somewhat self-correcting in that there will be outbreaks and then there will be less hesitancy. But what is not self-correcting is the destruction of US assistance and partnerships in global health, which are already resulting in the deaths of children from malaria, in the interruption of treatment of HIV, in the development of multidrug resistant tuberculosis. On the tuberculosis front, I think we really have to think of a two-track program. First, we need to do better implementing what works today. It's very frustrating as a tuberculosis doctor to see how many people don't get the treatment that would cure them, how many deaths there are that are avoidable, how many people who don't get diagnosed, because this is manageable, but it requires good management, the eradication of bad management. The other are new tools, and I don't know what's going to happen with the vaccine trial, but Tony and I have been talking about this for a couple of decades. An effective vaccine against tuberculosis would be a Nobel Prize. BCG prevents TB meningitis in infants. It's not effective in reducing TB in adults. So we need a good vaccine, but it's hard. Science sometimes moves fast. The COVID vaccine was amazingly fast, based on 20 years of research from dedicated researchers who didn't give up. But sometimes it really does take a long time because we don't have the answer, and we always have to start with, based on what we know now, this is what we recommend. In terms of what are the common causes, so it's a great question. I think one of them is primary care. I think we could get consensus across the political spectrum that we shouldn't be spending 20% of our economy on healthcare, and a third of our people can't get healthcare. And of the people who get it, most don't get good care. So now that requires the formula. That requires understanding the opposition. Who are the winners and who are the losers? How can we empower the winners and mitigate the opposition of the losers? Because frankly, the fancy hospitals and the specialists, they're going to hold on. So we need to figure out a strategic way to make those policy changes. I think there are probably things in safe water, safe food, safe environment that can get common cause. At a community level, there's an interesting policy called complete streets, where you have streets that are more walkable, and that also really helps the local businesses, and it reduces illness and injury and pollution. So there are areas, but they're going to be somewhat community specific and somewhat timing specific. Timing is really important. In policy change, a window of policy change can open and close in an instant. And so being ready, thinking about those opportunities, building the alliances in advance, sometimes it'll result in rapid progress and sometimes it won't. But, you know, like Wayne Gretzky, the hockey great, said, 100% of the shots you don't take, don't go in.
Can I scoot back to the questions? Well, I think we'll go through the rest of the questions, and we'll let them have final words. Yes.
Hi, my name's Anhat Kataria. I'm studying biophysics. I'm an undergraduate. And I had a very similar question about tuberculosis. Because we have a vaccine that doesn't work, a lot of extensively drug-resistant TB, drug regimens can last up to a year. Like, where are most of our efforts right now focused on in research and like treatment side, and like does that align with where they should be focused?
Thank you so much.
Hi, my name is Avery Simon. I'm a sophomore in the SFS studying science technology, international affairs with a focus on global health. But I guess my question kind of related to what you said about hypertension being one of the leading causes of death. How would you say that you could effectively get people to start focusing on their health and seeing it as a priority? Many people nowadays, they focus on their job and things that are at the forefront of their mind and affecting themselves and their family. So how would you say you can start getting people to think about putting less salt on things or focusing on little pains or things that might develop into bigger problems in their lives? Would you say that's more like policy effective or information effective?
Excellent. Next.
Hi, Dr. Frieden. Thank you so much for coming out here tonight. I'm Thomas Hampton, a sophomore at the SFS, and I certainly don't remember, but we met almost 11 years ago at the CDC Family Night during the Ebola epidemic because my father, he was working at Sierra Leone for the CDC. He's worked at the CDC for almost a decade and a half, and he was fired this summer as part of the president's war on the civil service. And so I was wondering, like, what are your and Dr. Fauci's advice for people about how to build a talent pipeline and maintaining the pool of public health expertise and public health experts in this country, so in 4 or 5 years' time, we can come back and rebuild the institutions that are being gutted right now. Thank you.
Excellent. We need to move through quickly, so.
Hi, my name is Anjali Walsh. I'm a freshman in the School of Health studying human science, and I wanted to focus a little bit on the role of developing technology and misinformation. So obviously in this day and age, AI is like rapidly advancing, and that's made misinformation much to more of an extreme, and then that's even more compounded by like the existence of social media, which kind of solidifies echo chambers. And so my question was kind of how do we combat that, and how do we make it easier to find out or differentiate what is the truth and what isn't for the average person?
Excellent. Thank you. Next.
Hi, my name's Zane. I'm a freshman in the School of Foreign Service. Dr. Frieden, you kind of talked earlier about, you gave the example of Coke and Pepsi working together to break down the soda tax in New York. So along those lines, how do you approach in public health working with and against these companies that have immense like political and economic sway, especially when they perpetuate a lot of these public health issues? Thank you.
Excellent. Next.
Good afternoon. My name is Jacob.
I can't keep up.
I know you can give some closing remarks. I just want to let them express their views.
Handle a few of them.
Good afternoon. I'm Jacob Levin. I'm a freshman studying international politics in the School of Foreign Service. And my question is, why do so many people believe in the lab leak theory, do you think? Why do some of the US government departments endorse this theory? And what does the science show us for the merits of this theory versus the zoological origin theory?
Great. 2 more. Make it quick. Oh. Nope. Okay. Well, last one.
Okay, I think I heard somebody say best for last. Is that what happened? Hi, I'm Max. I'm a sophomore in the School of Foreign Service. I don't think I'm going to have the opportunity to share this information at any other point, so I do want to let you know that my username on my computer for the last 5 years has been Dr. Anthony Fauci for no particular reason. So I'm just sharing that today, just letting you know. I hope that's the first time you've gotten that. My question is that you are 2 men with phenomenal distinguished careers. I'm wondering, as you sit in a room full of a lot of people who are students, haven't yet begun their careers, if you could zoom out a little bit in a more meta way. I know maybe won't have the chance to really talk about it in a meaningful way since we had a million questions, but talk about sort of how you figured out that you wanted to do what you do, and any heuristics that you used, any like aha moments that were useful for you and that might be helpful for students who are still figuring out the landscape for their careers.
Excellent. You each have 30 seconds. I'm just
So, we'll try to get to some of them. The last question, I think I'll tell you what my own personal feeling was, is that you already differentiated yourself in some respect by where you are right now. But you will find something that you can be passionate about. You might not have it in your grasp yet, but when you do, just embrace it, because the fields that we're in right now, in health, at least the fields that Tom and I are in, the gratification that you can get out of asking questions, answering them with the ultimate goal of alleviating suffering, preventing disease, or preventing premature death, there's nothing like it. And you're going to find it. I mean, I didn't quite know when I was in medical school exactly what I wanted to do until I got experience with a bunch of things. And then when I focused in on the arena of infectious diseases and the interface between infectious disease and immunology, it was like you were falling in love. I mean, it was something that you really, really cared about. So I would seek out that passion, and don't walk away from something because someone else might not think it's the best thing for you to do. Do what really turns you on, because if you're going to be successful and you're going to enjoy it, you've really got to love it. You can't go into it kind of feeling, well, it's just a job. If it turns out that you're saying it's just a job, you probably are not in the right field.
Thanks. Well, a lot of the questions were about what to do now, how do we make progress? And I think there's a combination of things of trying to stop some of the things that are very destructive. And we are seeing some response. So today, for example, it turned out that the staff who had been riffed, it's called, or basically laid off, were unriffed, that's a new word, who were running the National Health Center's, the Center for Health Statistics, National Health and Nutrition Examination Survey. That's really important survey. So they were brought back on. So speaking up can make a difference. And then creating, it's not building back, it's building forward. A public health that's faster, that listens better, communicates better, is more engaged, has better and more powerful alliances with others. Thinking about, yes, rebuilding, but building better. And looking at what worked well in the past. When I joined CDC in 1990 as an EIS officer, we were told if a state, city, or country asks for assistance, you will be on the plane before the sun sets or someone else will be. And that's an important ethos that we need to continue. I think the issue of companies, there's a range. There are companies that are very promoting of health. We want fitness companies. We want healthy food companies. And then there's the tobacco industry and at the other extreme. And we need to look at that and be clear, we're not anti-industry, we're pro-health. And there are a bunch of companies that'll do better if their workers stop smoking, because they'll have lower healthcare costs and higher productivity. So it's not as if, companies bad, public health good. We're all really trying to do the same things, and there are more responsible companies and less responsible companies, and we try to work with the ones that are more responsible. The issue hypertension and prioritizing, we really do think that the essence is the structural things, that we don't blame the victim. We try to say, look, yes, we know that it's hard to take medicines every day when you feel fine. But look at Kaiser Permanente, it's the same population, and they have 90% control. So the people aren't different, it's the systems. And we need to put in systems that don't absolve individuals of responsibility, but make it easier to do the right thing. That's the essence of what public health does.
Right.
The essence of what public health does is to structure society so that you don't have to think about it. You go about your business, you don't end up disabled, disfigured, or dead at an early age.
So the person who mentioned this idea about people getting fired and throwing out, it's the one thing you have to be really careful of for those who have, and I think many people in the audience do, have an interest in some element of public health, either directly or indirectly. Please don't get discouraged by what is going on right now. This is an aberrancy, and it cannot last. It cannot sustain itself. Besides the people who are getting hurt, the people at the CDC who are getting fired, the people at the NIH who are getting fired, that's an immediate effect that is terrible. It's cruel and it's deleterious to the public health and scientific effort. A more insidious, longer range effect would be discourage people like yourself from making a commitment in public health, because we need you. If we're going to get to the kinds of things that Tom and I have devoted our lives to, if we want to keep that up, we need you. So please don't look at that and say, wow, I don't want to have anything to do with that, because then you would have actually played into this diabolical scheme of diminishing our capability of public health.
What an honor.
Let me just really quick.
Go for it.
Technology is a tool, and it can be used for good or ill. AI has tremendous potential to do good. There are also risks, and a question came up about lab leak. I didn't want that to go unanswered. We may never know, and we will certainly probably never agree on what caused the COVID pandemic, but it's certain that there's too much risk of lab leak. It's certain that we had a smallpox leak in the UK. We had an anthrax attack. We had a SARS leak in China. We probably had a flu leak in the Soviet Union. So we need to do more to reduce those risks. And the last thing I'll say is that the question about jobs and about what to think about. In my view, what you want is a job that checks 3 boxes. One, that you believe that what you're doing is meaningful. 2, that you're continuing to learn, because we all love learning. It's exciting, it's interesting. And 3, that you enjoy the people you work with. And with the kind of energy and enthusiasm that you all have, I'm confident that you can find those great jobs.
On behalf of the STIA faculty, I want to thank you both for joining us tonight. It was such an incredible honor to learn with you.
Great to see you.